Bismillahirrahmanirrahim. Assalamu alaikum. My name is Sayyid Usama Ali. My roll number is 1650221. I'm a final year student of morning group, and the topic I've been given to present is rational and irrational use of drugs. The subtopic is intraperitoneal dialysis solution of appropriate composition. So first of all, we should know what intraperitoneal dialysis solution is. Intraperitoneal dialysis solutions are sterile, non-pyrogenic solutions in flexible containers, which means they don't contain any kind of microorganism, even not a single microorganism is present. Intended for intraperitoneal administration only, the peritoneal dialysis solution contains no bacteriostatic or antimicrobial agents. It is a hyperosmolar solution. It means that they are intended for intraperitoneal administration only and cannot be given IV or by any other oral or by any other route. The peritoneal digestion solution contains no bacteriostatic or antimicrobial agents, which means they are free from any kind of antimicrobial agents. It is a hypersmolar solution, which means this is the principle of filtration, which we later on see on. This is the principle. An osmotic gradient must be created between the peritoneal membrane and the dialysis solution in order for ultrafiltration to occur. The hypertonic concentration of glucose in the intra-PD, which means intraperitoneal dialysis solution, exerts an osmotic pressure across the peritoneal membrane, resulting in transcapillary filtration. So basically, in this point, it is being discussed the mechanism of action, the principle behind this peritoneal dialysis, which is ultrafiltration. Now, coming to the major topic, rational use of the intraperitoneal dialysis solution. The peritoneal dialysis is a type of dialysis technique, one of the most effective treatment options for patients with ESRD, which means end stage renal disease. Basically, there are 4 to 5 stages of the renal disease, acute and chronic, and other types. Among them, the last one, class 5 is, the last one is the end stage renal disease, where there is no other option except for the dialysis, which could be either peritoneal dialysis or the hemodialysis. For this purpose, a dialysis solution is used, which must be in the appropriate concentration and composition. Now, the irrational use of the intraperitoneal dialysis solution. An average PD patient, an average peritoneal dialysis patient absorbs about 60% of the dextrose in each exchange. This continuous supply of calories leads to, which means that in the dialysis solution, we later on see on the composition of the solution, but it contains 60% of the dextrose at least. And this much amount of dextrose would be absorbed, which means that there would be a continuous supply of calories that could lead to increased adipose tissue deposition of that, decreased appetite, malnutrition, altered requirements for insulin in diabetic patients. Apart from that, the most significant complications among the patients having peritoneal dialysis is peritonitis, which means that if it is being taken irrationally or there would be an irrational use, it could lead to peritonitis, which is the inflammation of the peritoneum. Also, as a result of the irrational use, there is a potential for overdose resulting in either hypervolemia or hypovolemia. Electrolyte disturbances are also there. That is, peritoneal dialysis may affect a patient's protein, water-soluble vitamins, potassium, bicarbonate, calcium, magnesium levels. All of these electrolyte level would be imbalanced. So we have to monitor hematology, electrolytes, blood chemistry, and fluid status periodically and take appropriate clinical action. Also, there could be hyperglycemia. Now, coming to the alternative choices of the intraperitoneal dialysis solution. First of all, there is no such alternative choice for peritoneal dialysis solution. Reason being that obviously we have to do the peritoneal dialysis, and for that purpose, we have to use the peritoneal dialysis solution. There are no other treatment or the dosage forms or the alternative choices available for us to perform the peritoneal dialysis. It must have to be performed by the use of peritoneal dialysis solution. However, the composition of the solution, the time of exchanges per day can be altered or adjusted according to the patient's condition and requirement. The initial CAPD, which means continuous ambulatory peritoneal dialysis prescriptions for most patients, consists of 3 exchanges during the day with 1.5% dextrose and a 4th overnight exchange with 4.25% dextrose. It means that to sum up all this, it means that there is no alternative choice. Rather, we have an option that we could adjust the composition of this dialysis solution likewise or accordingly to the patient's requirement. Fluid retention is solved by increasing the dextrose content of the daytime exchange, beginning with 2.5% in place of the 1.5% solution, and therapy can be further adjusted as necessary. For patients with excessive fluid removal, it may be possible to decrease the number of exchanges per day as long as adequate solute removal is present. So in these 2 points, it has been explained that we could adjust the composition of the dialysis solution, or we could change the or adjust the number of exchanges so as to get the optimum treatment or the optimum dialysis according to the patient. So now coming to the appropriate composition of the peritoneal dialysis solution. All the forms of peritoneal dialysis use dialysate solutions, which are commercially available in volumes of 1 to 3 liter in polyvinyl chloride plastic bags, which are flexible. The most commonly used solutions that are commercially available contains glucose or isodextrin, or called as icodextrin, with varying concentrations of electrolyte. Icodextrin is actually a glucose polymer. So here is the appropriate composition of a peritoneal dialysis solution, where dextrose is 1.5%, 2.5%, 3.86, or either 4.25%. Or if you're using icodextrin, which is a glucose polymer, the concentration would be 7.5%. The sodium would be 132 milliequivalent per liter or millimole per liter, chloride 96, calcium 2.5 to 3.5, magnesium 0.5, and lactate would be 40 milliequivalent per liter or millimoles per liter. Here's a pie chart representation of the same composition of the peritoneal dialysis solution, but just to present it in that way, I've made this slide. Now coming to the brands for the peritoneal dialysis solution, CAPD, which is the brand name, and the company name or the market name is RG Pharmaceuticals, which have produced this product. The other one is the Daniel PD2 peritoneal dialysis solution with 1.5% or 2.5% or 4.25% dextrose, which is by Baxter International. Now the available dosage form of peritoneal dialysis solution. As already we have discussed that we cannot give peritoneal dialysis solution in any other dosage form. Yani they can't be given orally, or they can't be given topically or transdermally or any other by any other means. The only route is parenteral. And that too, when it comes to parenteral, we can't give it IM, we can't give it IV, we can't give IA, we can't give SC. The only available possible route of administration is intraperitoneal. So the solution could only be administered parenterally in by intraperitoneal means, and even can't be given as intravenous. And there are no other any kind of dosage form apart from this solution for intraperitoneal purpose can't be given for these dialysis solutions. Drug interactions. As with other dialysis solutions, blood concentrations of the dialysable drugs may be reduced by dialysis, which means those drugs whose concentration can be reduced by the dialysis should have to be dose adjustment should be there. Diabetic patients may require dosage adjustments of insulin and other treatments for hyperglycemia, and those patients who are on the diabetic oral hypoglycemic therapy for diabetes, or who are taking insulin, both of them, either the oral hypoglycemics or the insulin, those must be adjusted accordingly. In vitro studies shows the following medications have demonstrated stability of heparin antimicrobials. These are some of the drugs named such as heparin and other antimicrobials such as amphotericin B, ampicillin, cefazolin, cefepime, cefotraxone, ciprofloxacin, erythromycin, and penicillin G. All these shows better stability, and these are the drugs which doesn't dialyze, which are not dialysable by the intraperitoneal dialysis solution. Now come to the case study. Case study. MJ, a 53-year-old male, 6 feet 5 inches tall, and weighs 70 kg, presented to the emergency room ER with complaints of shortness of breath, lower extremity swelling, nausea, vomiting, diarrhea, altered taste, sensation, and decreased urine output. He has been experiencing these symptoms from the past 2 months. Other complaints include blurred vision, diarrhea, extreme weakness. He has a history of type 2 diabetes mellitus and hypertension for about 4 years. Currently, he is on a combination therapy of losartan 1000 milligram per oral once daily, 100 milligram, and ramipril 2.5 milligram per oral every day for hypertension. For diabetes, he is taking a combination therapy of sitagliptin 100 milligram once daily and glipizide 5 milligram once daily before breakfast. His physical exam findings shows the following result. His temperature is 97.7%. 97.7 degree Fahrenheit. Respiratory rate is 20 per minute. Pulse 91 beats per minute, and blood pressure is 177 per upon 80 millimeter of mercury. His CBC is normal with a slightly decreased level of hemoglobin, that is 10.9, and for males, since he is a male, around 14 is the normal. So his with a slightly decreased level of hemoglobin is there. His electrolyte levels are as follows: sodium 138 milliequivalent per liter, potassium is 4.9, chloride is 112, serum albumin levels are 3.2 gram per deciliter. His renal function tests are as follows: BUN 132, that is blood urea nitrogen is 132 milligram per deciliter, creatinine is 21.8 milligram per deciliter, and its GFR level is, yani glomerular filtration rate is 3 ml per minute or 1.73 to a meter square के हिसाब से. What are these patients' most striking clinical and laboratory findings indicating, and how this patient should be treated? SOAP notes: subjective, objective, assessment, and plan. Subjective: the gender is male, age 53 years, height is 5 feet 6 inches, weight 70 kg. The chief complaint for which he has presented to the hospital are shortness of breath, lower extremity swelling, nausea, vomiting, diarrhea, altered taste, sensation, and decreased urinary output. Onset of chief complaint is 2 months. The current medications he is taking for hypertension and diabetes are losartan, ramipril, sitagliptin, glipizide in the respective doses mentioned beside them. Past medical and surgical history: type 2 diabetes mellitus and hypertension for about 4 years. No significant surgical history, which means that no, as such, there wasn't any kind of surgical procedure performed on the patient as such. But when it comes to a history, he has been suffering from type 2 diabetes mellitus and hypertension for almost 4 years. Objective: vital signs includes temperature was 97.7 degree Fahrenheit, respiratory rates for 20 beats per minute, pulse for 91 beats per minute. Sorry, respiratory rates for 20 per minute. Blood pressure 177 upon 80 millimeter of mercury. Physical exam findings and laboratory data were: CBC is normal with a slightly decreased level of hemoglobin, 10.9 gram per deciliter. Electrolyte levels include sodium 138 milliequivalent per liter, potassium 4.9 milliequivalent per liter, and chloride 112 milliequivalent per liter. The serum albumin level are 3.2 gram per deciliter. The renal function test, because all of these symptoms were indicating the patient suffering from any kind of renal disease, so the renal function tests were performed. The first test was blood urea nitrogen, which indicated the level of the test result 132 milligram per deciliter. Creatinine was 21.8 milligram per deciliter, and the estimated GFR, which is estimated glomerular filtration rate, was 3 ml per minute per 1.73 meter square. So let's start the assessment and the plan. Assessment: the patient's markedly elevated blood urea nitrogen and serum creatinine levels and a markedly decreased estimated glomerular filtration rate are clearly due to end-stage renal disease. So it means that our patient is suffering with stage 5 chronic disease, that is a very severe or the end-stage kidney failure. Because of the fact that the blood urea nitrogen and the serum creatinine levels were markedly high, there were very increased level of all these, and also there was a decreased level of the GFR, which means, as we know that in the kidney function, if it is abnormal, the GFR is decreased or the blood urea nitrogen or the creatinine levels are increased, which are indicative of this end-stage renal disease which the patient is suffering from. The plan: the treatment of this condition is either the renal replacement therapy by hemodialysis or by the peritoneal dialysis. So we should have an idea of what peritoneal dialysis basically is. Peritoneal dialysis is a safe and effective option for patients with kidney failure who needs dialysis. It offers several advantages in over center hemodialysis, and it may be the right option for so many people. For the purpose of peritoneal dialysis, an intraperitoneal dialysis solution or appropriate composition is used. As we have already discussed the composition of the intraperitoneal dialysis solution, an appropriate composition must be used in this case. Also, the doses of hypertensives, antihypertensives, and oral hypoglycemics he is currently taking should be adjusted accordingly. So let's discuss a peritoneal dialysis, a brief overview. Hemodialysis requires an artificial kidney machine to filter the blood, while peritoneal dialysis does not. Peritoneal dialysis, rather than using a machine, uses the lining on the inside of the belly as a natural filter for blood. Peritoneal dialysis is performed using several different modalities, including the most common CAPD, which means continuous ambulatory peritoneal dialysis, which is the manual process of dialysis. Development of specialized devices to facilitate the exchanges processes and improve the patient convenience has led to a process referred to as APD, automated peritoneal dialysis. So basically, in this slide, we have discussed the two types of peritoneal dialysis, either continuous ambulatory or the automated one. All of them, either CAPD or APD, both requires the use of a peritoneal dialysis solution, an intraperitoneal dialysis solution of appropriate composition. The initial CAPD prescription for most patients consists of 3 exchanges during the day with 1.5% dextrose and a fourth overnight one with an exchange of 4.25% dextrose. This would be expected to achieve the fluid removal of approximately 1300 milliliter based on 200 ml from each daytime exchange and 700 milliliter overnight. Based on assessment of the patient's fluid status, it may be necessary to increase or decrease the dialysis prescription to achieve the fluid balance. As already discussed previously, that we could adjust the number of exchanges or we could adjust the composition of the dialysis solution, the intraperitoneal dialysis solution, according to the patient. References: all of these books and websites or the articles were used during the preparation of this presentation. Applied Therapeutics by Koda Kimball, Pharmacotherapy, Joseph D. DePirio, Improving Survival in End-Stage Renal Disease, which was a case study on the ResearchGate, an article, case report, another case study, treatment of end-stage renal disease with CAPD, NIH government website, and the 2 other websites to get the information about the drug. The dialysis solutions information was taken from drugs.com and rxleaks.com. Thank you.